guys' thoughts on taking these perspectives a little upstream when we still have maybe a few more tools in our arsenal? Do you think the later conversations become easier if we broached them when we do have more sort of tools at our disposal? We start having these quote unquote palliative care discussions or bringing some of these concepts and principles upstream when we still have a few options and priming people. Just, I think back, to take it totally out of context, the second I order an MRI for an elevated PSA, I'm already talking about a biopsy. And the second I get the biopsy results, before I order staging, I'm already talking about different ways that this can play out. And so to what degree do you think there's maybe some role for forecasting the future, not to doom someone to it or cause unnecessary duress, but to sort of, offer a realistic set of opportunities, knowing, we have a few more things we can try, but, we're already at second line. The chances that we're gonna cure this are virtually, nil. And here's what our goals are, and how can we, employ the tools at our disposal along this path to help you get to the good destination. How early do you think is too early, or is there too early?
That's different for each patient probably, and their disease and the treatment options that you have available at your site. But I think that it's important, and it's a very delicate balance, because when you have patients with incurable cancer, they also need to have hope. And that hope is what carries them on days that are really tough. So I think that it's important to kind of signal we're using up our options, and we have options left, but we want to think really carefully about them, because at some point we won't have as many. And so it's okay it's important to forecast that, because you certainly, I think of it as a failure when I get to the end and I realize I don't know that I've ever really had this conversation, and that happens pretty rarely, but sometimes
you don't want people to be surprised.
You don't want someone to be surprised, but sometimes even with the best of intentions, it does happen. So a couple strategies are engaging with palliative care for symptom management when the symptoms are just starting off. Even when we have, at least in my practice now, I don't prescribe as many narcotics just because of the way things flow in my clinic. I often will engage palliative care for some of the long-acting narcotic use. And when that's happening, that's often a time when palliative care can also contribute to some of those conversations around long-term forecasting. Engaging with team members to also have them kind of be on the lookout and thinking about supportive services, and also to give me and the rest of the team kind of feedback, because we don't all always see it either when people are declining. And I remember having check-ins with Brenda, am I seeing this guy properly? Because it looks to me like he's starting to decline, and she'll say, yeah, I've been noticing that for a few months. Glad you caught on. So that's really, really important to have those check-ins and to make sure. But I also just want to reemphasize those W words, because I worry that this is happening to you. I wish that I could do everything and anything for you, but I wonder if this is still the right path, that we might need to go down a different one. And those W words can be so powerful and really helpful for communication, but also just kind of getting everybody on the same page. But I wonder, again, from Brenda's perspective, because I really think that having the team is so helpful as we reach some of these later phases of disease management.
I think it's also kind of, yes, this is something that shouldn't come up at the end because it's too late. I think early on, if symptoms are happening, just educating the patient that palliative care is different than hospice, and it's symptom management. And so you kind of open the door for adding that other group into the mix. And we know that with better symptom management, you'll have fewer side effects. That's the goal. Your quality of life hopefully will improve. And then it's like you have this multidisciplinary team kind of all looking out for what's best for you. Excuse me. And palliative care doesn't really, their focus is on symptoms regardless of cause. So they're always going to be somebody who is on the team with you going forward. And then also just checking in with patients and making sure that they're not, where was my thought going with this? I think it's just like checking in with patients, introducing it in sort of a non-threatening manner, that this isn't end of life, this is part of the cancer care. And again, these are our goals with this. And then as treatment, I agree totally. As options is they move, like if it's prostate or if they're moving from first line to second line, depending on what disease site it is, you know, the treatment options we have. And then also telling them, just like Jackie was saying, these are our options, but this one has like XYZ side effects. And I'm really concerned that right now you already have this happening. So I'm not entirely sure we want to add to that. So I think, again, it's just a team approach. It takes multiple members, multiple tries to get the information and to communicate things that on a level that patients can understand.
And also engaging family members. I think
yeah,
that's
definitely.
so helpful, pulling in other perspectives around the patient. And sometimes the patient's fully on board with kind of moving in a more palliative direction and families not, and vice versa. So leveraging whichever person is on the same page with you is also a strategy that I've had to use.
You alluded to this a little bit, but I'm wondering your thoughts on, you know, the notion, the stigma that comes with the idea of palliative care. You alluded to the difference between palliative care and hospice, but I don't know, maybe your patients handle a little bit differently, but I find that there's often an immediate visceral reaction that comes with the idea of palliative care. And so do you guys have thoughts or sort of communication tools or approaches that you think are helpful with mitigating that sort of stigma that comes with what is such a valuable portion of the cancer patient's care?
Well, I think it's important too that when you are talking about palliative care, it's not because we think that, I mean, I'll flat out say it, we're not dying. You know, at this time, this is the treatment, we are working on these goals. But I think I want to do everything I can to help you. And so this is where I think focusing on symptoms with the symptom management team, sometimes that helps a little bit too. And again, it shouldn't be a surprise as patients are declining. That conversation should come up as an option. You know, and I've had patients say, well, I'm not ready for hospice. And I'm like, that's fine. I'm just telling you this is an option, you know. And so just as you would say X, Y, and Z would be some treatment choices, I also want you to know that if you decided you didn't want to actively treat the cancer, that this would be an option for you. And so putting it on the table and then bringing it up on occasion afterwards. And again, you know, that can be a real conflict when patients are ready and family members are not, and the struggles that go with that. And also just letting them know they're not being abandoned. So we're not pushing them onto somebody else. You know, we're still involved. We're just adding team members.
And we have a terrible narrative around cancer and fighting and these words that go with it. And I don't mean to, there's a lot of people who, and my patients, where those words are really important to them and they give them strength and hope. So I don't mean to take away from that. But Brenda, when you're talking about bringing up hospice as an option, and you're talking to your patient about that, I will sometimes hear, I'm not ready to give up. I know we've all heard that. And I try to say, I hear you. What's your experience with it? What do you think about it? Like, how have you interacted with it before? Because it sounds like you know something about it or have heard something about it. So that allows me to sort of uncover misconceptions that might exist about what that means. Like, someone may think that that means that they'll be on really sedating medicines and not be awake, and right? And I say, actually, the point is that you're feeling as good as possible so you can spend the time with your people and you can enjoy this as best as you can. So I think that's important, and also reframing it as you're not giving up. For some of my patients, like, so much has come at you that is out of your control. You've had to just have something hit you and deal with it. And you've dealt with news after news after news. And I want to make sure that I'm giving you some amount of control over what this looks like. Because if a non-plan is a plan for rehospitalization. A non-plan means that things are going to happen that if we didn't explicitly talk about it, it may just happen, and we may end up in a place you may not want to be, or having a medical death that you did not want to have. And so I think reframing that as it's not giving up, it's trying to give some control is helpful.
Sort of proactive rather than a reactive.
Yeah, and no, that's a very great point and very well said. I frame it as a change in the emphasis of care, where we focus less on cancer-directed treatments, so treatments that affect cancer directly but cause, side effects, and focus more on, dealing with your symptoms and, making you feel better. And that's really the goal here. And it's not, you're not giving up the fight. You're no longer fighting. We're just, we're addressing this differently. And it's also hopefully not the first time that we've talked about symptom management, right? That's another critical piece where you introduce that much earlier on when there are still many treatment options left, and you do that in concert with the treatment options.